दी थी वलीद को भी और ज़ैर को भी ना।
We can
तो
start.
आप स्टार्ट करें।
Okay.
बिस्मिल्लाह।
Okay. Assalamu alaikum. Good morning, good afternoon, good evening. So to all the participants, so I welcome all of you on behalf of APPNA MERIT Research Webinar Series. So most of you are with us for quite some time, like over the last 2 years. This is going to be the 11th month of the second year. So we are engaged and we have covered a lot of topics on clinical research. It's like a 360-degree overview. We have invited the clinical site people. We have invited the clinical research organization. We have been inviting the people who are actively engaged in clinical research, the regulators. So we are moving, the clock is turning. So today we feel very, very excited that we have a very respected and, uh, I mean, unbelievable. I do not find the word how he is going to change the landscape of healthcare capacity building in Pakistan. So we warmly welcome Dr. Shahzad Ali Khan, who is a medical graduate from King Edward Medical College, now University, back in 1991. So he is among the very, very few doctors who also did his MBA with major in finance and MSc in public health from Quaid-e-Azam University. So he's one of the very, very few medical doctors with a PhD in management sciences in Pakistan. He also holds fellowship of Royal College of Physicians and Surgeons, London, UK, and also holds fellowship of Royal Society for Public Health, UK. He has 192 publications in journals with over 27,000 citations, an H index of 65, I-10 index of 565, which is by all means a phenomenal. He is the Vice Chancellor of Health Services Academy, Islamabad. So Health Services Academy may be a misnomer in a way. It's a proper university and they are going to grant the degrees. So that is a very, very brief introduction of Dr. Shahzad Ali Khan. I also welcome two of the panelists, Dr. Akhtar Hamid, who is Associate Professor with University of Toronto, a very active pediatrician. He is also actively engaged in research and holds another title of President, Canada, Pakistan Research and Development Council. He is engaged in the audit of healthcare facilities in Canada. So he has many hats. So we very warmly welcome Dr. Akhtar Hamid to be a panelist. And, extreme joy to introduce Professor Dr. Sarwat Hussain, again, a Kamkolian. So this is a galaxy of Kamkolians. Dr. Shahzad is from King Edward. Professor Sarwat is from King Edward. He is a radiologist, an author, an innovator, whatnot really. Dr. Sarwat is an amazing personality, having a great taste for poetry too. I always take the liberty to share some of the poetry with Dr. Sarwat Hussain. So with this, I will request Dr. Shahzad Ali Khan to please start his presentation. Over to Dr. Shahzad.
Gee, thank you very much, Dr. Uzair. And it's a pleasure talking to you, all of you again. I think last year during COVID, I had a chance to present some of the findings of how we survived in COVID in Pakistan and what we did. So it was quite a long gap in between. I hope to minimize this gap and come up regularly and share some of the experiences which we are doing and facing in Pakistan. Today's presentation is of two major portions. One is what are the challenges, health indicators, and some of the statistics I will share for say let's 10 to 15 minutes initially. and then I'll talk about what we are trying to do in Health Services Academy. So Uzair actually asked me to update us the forum in Canada and of course North America, US, and in Europe. Most of the Pakistanis are too much worried about the situation in Pakistan, especially the health system, and they want a very good will and good intention to improve this condition. So anyone who is doing something good, they always support, and they actually come ahead and try to build the momentum which anyone wants to do here. And Uzair is like one of the great friends of Pakistan, frequent traveler, and whenever he comes, he connects me to some very good performers who are like moving in the right direction. There are few, but there are people who are trying to do good, and hopefully we will make a team and things will improve. So there are two parts thing, one about the health situation in Pakistan, health system issues and challenges, and of course what HSA can do and what actually we have done. I will not share only the sad story. I will tell you about something about our future vision and how we can connect to enhance this impact, which is very little right now because we are only based in Islamabad and we have to move out of Islamabad to make an impact. But definitely we will try to do something more. So if we talk about like this Pakistan, so you have a very, very good urban settings, pictorial view. If you see, this is Pakistan. So you can easily see there are one of the beautiful cities. So Islamabad is one of the best capitals in the world. And most of our cities, they have some very scenic urban beauty. So this picture tells you a story that you can't see this picture and think of that something is bad in this state. It's beautifully built. If we talk about rural, we have one of the best rural landscapes in the world. I am also a traveler, frequent traveler to northern areas of Pakistan and other areas in the mountainous areas. So we find those scenic views, which most of the time Sayyid Uzair shares on the Facebook about Canada and America, and we are amazed to see that. But when we go into the periphery, we also find such beautiful pictures over there. So this is Pakistan. This is Pakistan. We have this is this also in Pakistan. So this is one of the view, one of the side of Pakistan, very advanced, very developed, having all the amenities and beautiful housing societies and plazas and everything. One of the magnificent buildings of PM House and other things. But there is another side of Pakistan. So whenever you zoom in to these pictures, which I showed you, so when you zoom in, the problem is from a different view, from a far view, things are pretty much good. But when you get into it, like a public health professional, they go into the field, they go into the depth of societies, you find a different picture. So this is Pakistan also, and this is a Biko Road, Lahore. But there are many other pictures like this. You can easily see that. This is Gujranwala. Then this is Khairpur and area of Sindh. And then this is also Matiari district, main road in front of a DHO office, unfortunately. So this picture was taken by myself. So this is also Pakistan. So there are two faces of Pakistan. Unfortunately, from a distant view, sitting in a five-star hotel, sitting in a luxurious university cabin, or sitting in an airplane, you find the previous pictures. But when you go into deeper, you find these pictures. So that's why there is a nomenclature that there are two Pakistans. So this is a reality as well. And a public health professional and a policymaker has to think about this before making any policy. When you come to people of Pakistan, well, the new, you have seen this new census, which was done a few months ago. It was made public. Pakistan's population has exceeded 241 million. So we can say, yeah, well, they are too many. So on health system train, this is the situation we have in Pakistan. So whenever we talk about people of Pakistan, the picture is like this. It's every system which is there is overburdened by the humongous growth of unplanned, monitored, unchecked, rapid growth of 2.55 percent times. Like, so this is a very, very big growth rate of 2.55. we were thinking of we are reduced to 2.1 or 2, but new census has told us that it is not decreasing, it is actually increasing in the last 20 years. So the population growth has so many implications on multiple things. People of Pakistan are also like bipolar, like two types of extremes in Pakistan. As a policy maker, I have to take notice of this, and we should actually, because we are Islamic Republic of Pakistan, so whatever we are doing, we should be in compliance with all the teachings of Islam, and of course, it should be not be detrimental or against the religious beliefs of the people. So that is one challenge the Pakistani policymakers have always. Whenever we talk about policy, we have to keep it like conservative, and we have to take care of the emotions of the people who are in majority. But there is another rising trend of what we call it as more progressive, advanced, and modern Pakistani population. In all cities and all districts of Pakistan, there is a growth of young people, youth, who are actually quite progressive, and they have different priorities. So when it comes to policy making, we have to take into consideration these two aspects of Pakistan as well. That in Pakistan there are two types of people, and in between there is a median sort of mixed population as well. But there are two different extremes who both of them are quite in a majority nowadays. So about health system in Pakistan, you can say we have a syndrome which is known as a mixed health system syndrome. What is it? Dr. Sania Nishtar coined this statement, and we used to call this mixed health system syndrome because Pakistan is one of the few countries where we have both the public sector, very large public sector. In fact, WHO claims in the report of Primary Healthcare 2008, WHO claimed that Pakistan has one of the largest infrastructure of health in the world. So government sector. So Pakistan's government sector is very big. So there are around 300,000 doctors, 110,000 beds available in the government sector, over 100,000 various community health workers like lady health worker, community midwife, and outreach staff. And we have around government facilities of ranging more than 16,000. I think the 972 are the big hospitals, and remaining are various BHU, RSC, THQs, and district headquarter hospitals and other dispensaries and TB centers. So we have quite large public sector, but except for the tertiary care facilities, the primary and secondary care is mostly having very poor coverage, very low coverage because of multiple issues. That today is not the day to talk about that. We can have a discussion on how to enhance the primary and secondary care utilization in Pakistan. I worked on those areas. So, but public sector, very large, very big across the country, limited coverage at the peripheral level, and a very overutilization of the tertiary care facilities. We have a very big private sector. That's why we call it a mixed health system syndrome, because public sector is very huge and private sector is even larger, but mostly unregulated. We have commissions, we have authorities, but their actually regulation is limited to certain complaints and other things, reactive type, not proactive type. So when we talk about how much population is accessing is government sector versus private sector, so you can see 70% Pakistanis, they go to private sector, 20% Pakistanis, they go to government sector. The remaining 10% gap is actually, unfortunately, of those who neglect to care. So 70% Pakistanis go to private sector, 20% government sector, 10% is the figure which comes up again and again in our surveys. The people who do not go anywhere when they are sick. They do self-medication, they do some totka, some sort of traditional home remedy. So they don't go to the private or public sector, they do some self-medication or home remedies, which is a very big number, 10%. Another point to consider for my overseas fellows and friends, that you call this private sector, but unfortunately, this is not pure private sector we are talking about. So in Pakistan, one of the biggest dilemma for any policymaker, any government, is that the public sector, or I'll say government sector. So the government sector of the morning is the private sector of the evening. So there is a concept which is known as moonlighting. So whatever is happening in Pakistan in health system is because of this major problem of private hospitals owned by the government professors, government administrators, and government officials. That is a very strange thing. No one ever talked about it. We tried to do institutional based practice in KP and various areas. It failed miserably. So the private sector is not purely private sector. You will find a few hospitals who are purely private, and most of the time the GPs can be labeled as the private GP. So there are certain general physicians who are doing a private clinic and they don't do any work in the government sector. But majority of the hospitals, the clinics, they are run by the people who are working in the government sector in the morning, and in the evening they are doing private practice. And most of the private hospitals, they are visited by, they are also run by the government consultants and government clinicians. So that makes the thing more complicated for regulation and other things, because moonlighting is you create your private practice through your government job. So if you are a professor or you are a consultant in a government hospital, you will not be interested in, automatically you will not be interested in doing much over there, because you have a very big hospital in the evening. So most of your agents and most of your staff will send the patient to the private sector. The poor will, even the poor will not get good treatment in the morning, because he has to visit the private clinician in the evening and then get some favors back in the morning. So that's a very big messy thing. I don't know how to tackle that, but mind it, Pakistan do not have a pure private sector. It's a moonlighting concept of private sector created by the government public sector of the morning. Out of pocket spending, whether you go into the government sector hospital or you go into the private sector hospital, the problem is that you have to pay out of pocket. So we tried a lot of interventions and inventions and I'll say reforms, but I don't think that this out-of-pocket spending has gone down. A little effect was done by this National Health Insurance Scheme or Sehat Sahulat program, but the surveys are again and again showing that there is a huge burden of out-of-pocket spending in Pakistan, which is resulting in catastrophic expenditure of the poor and people going below poverty line. Just to give you one example, we did a survey, not a survey, we did an analysis of the survey findings of various HMIS reports and other data available in Pakistan. So the poverty survey linked with some of the catastrophic expenditure, we found out that disease or illness or health shock, we call it health shock. So the disease shock or illness shock was considered as one of the biggest poor producing phenomena. So the incidence of poverty in Pakistan, if 100 people go below poverty line, if 100 people go below poverty line in a year, 56 of those, they go below poverty line because of a health shock. So it's not disasters like floods or rains or earthquakes or job loss or industrial law, sort of divestment or economic thing. No, it's not because of economics and other things that people become poor in Pakistan. The biggest cause of poverty production in the country is disease. And not just the disease which causes catastrophic expenditure. So the middle class or the lower middle class have to take loans and spend their savings on disease, and in the private sector or of course in the government sector as well, and they go below poverty line. So that is one of the point to ponder, that out-of-pocket spending is killing a lot of people and taking them below poverty line. And once they are in below poverty line, definitely it's very difficult. That is very difficult to manage. I'll take the question at the end. So when we talk about this percentage deaths, so majority of the deaths in this country are now happening because of hypertension, heart disease, diabetes, and cancer. In children, of course, diarrhea and pneumonia are the major killer, but above the age of 5, overall, the biggest killer is heart disease. 47 deaths per hour is the at least minimal number in Pakistan. 47 deaths per hour due to heart disease, 1,128 deaths in a day, and around 4,32,000 deaths annually because of heart disease. And majority of these heart diseases are occurring at the age of less than 60 years of age. So 60% of deaths of heart attack in Pakistan, unfortunately and astonishingly, are lower than the age of 60. Similarly, you must have heard that this is a double burden of disease. So this is very difficult to manage. What are some of the lifestyle risk factors? Tobacco is very still high. And it's not just cigarette smoking. There is cigarette, pan, gutka, and naswar in different forms. tobacco is being used. Cigarette is, I think, more than 20-21%, but other are also very common: pan, gutka, and naswar in KP and Balochistan, and in many areas of Punjab as well, South Punjab. Very few people in Pakistan, they take vegetable servings every day and fruit serving every day. So the recommended one is 1 serving of fruit a day and 2 servings of salads or vegetable a day. Very few people take it. In leisure domain, the definition of physical inactivity is when you do not do any exercise in your spare time. In leisure domain, 90% of the population is inactive. They're watching TV or TV shows, news, which is another stress factor, anxiety factor, and half of them are either sleeping or not doing anything. So very inactive population in the world. So that is why 12 to 17% is the number. Various surveys coming up from 12% to 17% is the range of various surveys showing diabetes. 33 million diabetics in Pakistan. 1 in 4 adult is hypertensive. When you go above the age of 40 years, this is 1 in 3. So 1 in 3 Pakistani is hypertensive. 1 in 4 is like adult is hypertensive, and we have an epidemic of obesity and overweight because of all of the above. When you don't eat vegetable, when you don't eat fruit, when you are inactive most of the time, the population is going to be overweight. Very high prevalence of hypercholesterolemia. Basit Saab of Bakai Institute of Diabetes recently did a survey with me, and we found out that it has now reached up to 40%. So it's the range is hypercholesterolemia of young adults is about 40%. So the samples which we are collecting and asymptomatic, non-diseased, normal college, university guys, we just take the sample, and majority of them, almost 40% of them have hypercholesterolemia, where there is a recommended treatment for that. Diarrhea, again, I told you that this is 11% under 5 years, pneumonia is 6%. Stunting, wasting, and underweight in Pakistan is second highest after Afghanistan. We have 42% children who have less height for their age. So stunting is very high, wasting is very high, underweight is very high. That is a very big problem. 6 to 9% are the surveys results. There are some surveys who are now showing 9% hepatitis C. Unfortunately, it's not related to sex in most cases. In most cases in Pakistan, this hepatitis C is iatrogenic. It is hospital-induced. It is GP-induced. It is clinic-induced hepatitis C. Dentistry, GP needles use, around 80 million injections per year is a number which makes us one of the largest injection using nation in the world. And most of these syringes are reused and multiple time used, and same is the case with surgical instrument others. So hepatitis C is not like it's a sexually transmitted disease. Here, HIV and hepatitis C and B both are coming up as an iatrogenic problem. And you know the Ratodero Ladkana epidemic, which was due to a iatrogenic hospital-based, clinic-based epidemic in Ladkana. Anemia, one of the highest. Every second pregnant lady is anemic. Half of the deliveries are still happening inside the houses without any skilled birth attendant. So that is why we have one of the highest, not one of the highest, we have the highest newborn mortality rate in the world, 42 per 1,000 live births, which is very high. So that is something very, very challenging. Pakistan is the 3rd largest maternal deaths in the world, 4th largest child under 5 deaths in the world, and 5th largest TB cases in the world. So this is a very sad story. Polio, Afghanistan and Pakistan are now sort of trying to get hold of this polio situation, and cases are less now, but we are not achieving zero case for consecutive 2 years. That is a big problem. So coming back to my second part of this presentation, Uzair and Waleed, how much time you can tell me when the time is limited, okay? Hello.
You can carry on, Dr. Saab.
Okay, thank you.
Another easily 10 minutes here.
Okay, okay. So health system research spectrum, if we talk about, if you see this burden of disease, then you have to think like whether I need a biomedical research or what type of research in the country. So I'll just give you a spectrum, or maybe a sort of a range of health system research needed in this country, and then how we can integrate and collaborate with each other. So that is something which we will be doing. So when we talk about the spectrum, of course, there is a biomedical research which is needed to identify the physical and biological sciences, including various genetics, toxicology, pharmacology, drugs, clinical trials, and other things. That is going on at a very slow rate. It's not that much established. There are some CROs involved in this activity. But most of them are not, well developed, and most of them have left after COVID because the COVID research got research fatigue in the country, and all other areas other than COVID, they almost collapsed. So biomedical research is needed. Yes, some of us should be doing this research, and we have just signed an MOU with LUMS and some other universities where they have very good labs to conduct this biomedical research, life sciences research, because it is needed not only for the drugs and vaccines and diagnostics, but also medical devices. So this is something which is the future of biomedical research, this biotechnology, appliances, and diagnostics. But we need health policy and system research. Why? Because we have been struggling very hard for policy formulation. This country, if I am to present and say, use a word for policy reforms, in the last 20 years, we have tried so many reforms that I used to say that Pakistan is suffering from a disease called as reformitis. So we have a reformitis because every other manager, policymaker, or a senior minister who comes here and he tries something new without even evaluating the impact of the previous reforms. So we don't evaluate, we invent something new from like UN agencies and partner organizations and some other intuitive thinking, executive decisions, and we start doing that. So this is very much needed in Pakistan, policy formulation. We need to do research on policy formulation, relationship to evidence, and of course, prioritization of research activities. This will require us on the 6 building blocks, research on all aspects of that, efficiency, effectiveness, and of course, the access and scale up and monitoring and evaluation. We are not doing that. Only the donors projects are evaluated. The government projects are never evaluated. We need a very strong social science and behavioral research in Pakistan. That is absolutely needed because our health system is not embedded with the social science. It is purely medicalized. It is biomedicalized, and we have a disconnect with social sciences and behavioral sciences. That is a very big problem. So we need to think of how to conduct research on social and behavioral aspects. And definitely it will link equity and healthy lifestyle and health-seeking behavior and other lifestyle issues. And of course, program research, programmatic research, we call it, operational research as well. So that is one of the, I think we had a discussion previously with University of Manitoba. They have a module of program science, and basically program science is operational research. So I tried to connect and move forward with them, but there was a conflict between the thinking of how the Canadian system and their other projects work with Manitoba and how the Pakistani system is working. Unfortunately, Pakistan is not, Pakistan is like, you can say, an outlier of all of these research models. You cannot do anything which you are doing in any other country, or you cannot do this in similar manner over here. We have to localize it. We have to domesticate it, and then you can do that. So we need biomedical research. I told you why: health policy and system research, social science and behavioral research, and of course, operational research, because we have to see how our programs are working. We have not been able to evaluate and monitor and address the effectiveness of these programs, specifically the target to the poor. So I call it benefit incidence analysis, BIA. There are not enough health economists in the country where I can connect with them and we start some benefit incidence analysis. The first thing I will try to do is to identify the benefit incidence of the Sehat Sahulat program, the benefit incidence of BISP, the benefit incidence of any other social level program in the country. We have not done that. Unfortunately, small scale surveys, they do not tell us. And those too, by the donors, they always give you a rosy picture. So operational research is very much needed. So this is the spectrum of health research. What will happen then? Then we will be able to understand the biological nature of disease. We do not know the biological nature of Pakistani disease system, because Pakistanis, whether they are in Canada, whether in the USA or UK, they have a very high risk of getting NCDs and very high risk of getting heart disease, diabetes, and cancers, even if they are staying in UK or US or Canada, because of our genetic issues. So we need to understand those issues in Pakistan. There are so many researches done in UK and US, but I think we should come back to Pakistan and do something like that. But this understanding of biomedical research with this understanding of health policy and system research, social sciences and behavioral sciences and operational research, we will be able to understand how to test, scale up, and follow through the introduction of intervention and optimize their benefit. Without this four sort of areas of researches, if we do only one, it will not be of any use. So this is something which we need to do, and of course, it will need innovation. So that this is something which should be our outcome. Our main outcome should be, whenever we are talking about research projects, it should be innovative, and not just innovative. It should have an impact on the population, not on impact on publication or scientific like citation and anything else. I do not believe in this paper publication and sort of citation and H index and XY index. It's just nothing when you do not have any impact on population. So this is something which is needed. Coming back to now, what is HSA doing? Last, I say 5 minutes. I'll share with you some of the things which we have done. The first thing is my organization, like Health Services Academy, it's a university, is very, very simple in our future vision. We are following a principle of growth. Now, why I wrote this? Because most of the government universities of Pakistan, they do not believe in growth. They are static. They stay inside the campus. They ask all the people, all the students to come into the campus and then study and leave. Unlike the private sector universities of Pakistan, who are expanding like anything and opening campuses everywhere and expanding in various. So not just growth in expansion in the terms of physical expansion, but also accelerating progress in terms of quality. So if we are not enhancing the quality of our program, then our vision is not met. Diversification, I'll show you some of the departments which we created. We have moved out of the biomedical or medicalized model of public health, which we call it as community medicine. We are not practicing community medicine or a medical college or a medical approach. We are moving out of this medical field and moving into new fields of diversification. And of course, we are networking through partnerships. Every day you see, I usually share the pictures and news just to tell the people that we are partnering. We don't want to go alone. We want to take along the people, and we want to make a team. And of course, without empowering my faculty and my students through innovative teaching and research, I cannot achieve anything. So these are some of the key principles of future vision of HSA. Uzair and Waleed, I shared with you the presentation. I'll share again this one. And if anyone asks about this presentation, it's not a copyright presentation, it's copy left. So anyone can take this presentation and use it wherever they want to use that. I announced this just for the sake of people that this presentation, they can use it and they can refer to it. Transforming HSA, very simply, we started from degree awarding institute, and next year, hopefully, inshallah, we will be moving towards into a full-fledged university. Why? Because the degree awarding status, which is equivalent to a university, is given to someone who has one department. So we were made a university in 2018, but that was only a department of public health. So what we have done now is we have independent various 10 departments. So these 10 departments are School of Public Health, Rehabilitation Sciences, Pharmaceuticals and others, Public Dental Health, Public Mental Health, Nutrition and Lifestyle Medicine, Public Health Law and Policy, Center for Global Health, and Center for Sports, Fitness and Physical Education. So we have one of the best, you can say, people in each of the department. Every department has 3 to 4 PhDs. There are 3 to 4 PhDs from Harvard, Johns Hopkins, and Queen Margaret University, Edinburgh, and Liverpool, Manchester. So we have and of course, Karolinska. and Helsinki. So these doctorates who are working with us, around 30 of the PhD faculty members in these 10 departments. We have achieved the status where we can now move into a university, which is PC1 is also in process, and PC2 is approved. Hopefully within next 2-3 months, we will be able to start the building, a 7-story building, which is funded by the government of Pakistan, and we will be having one school at each floor, and of course 1 floor for library and parking and other things. So this is infrastructure is also. So we have HR, we have funding, we have partnership with a lot of our partners. So my focus nowadays is interdisciplinary studies. Translational medicine and interdisciplinary studies are 2 new things which have we brought into Pakistan. Public health needed that. We had to come out of this medical mode of public health and come out into a social science. We do not treat ourselves as medical doctors. We treat ourselves as social scientists and interdisciplinary range of various things. And of course, linking it with the society, we are getting a lot of collaboration with societies and various organizations who work in the field. So Center of Excellences are being established for quality of teaching. We were approached by one of the best universities of Pakistan, like Lahore University of Management Sciences, LUMS. We signed an MOU with them. IBA, Institute of Business Administration, we signed an MOU with them. Zabist, and of course NUMS and other, they are also our partners in many areas. Faculty development is going on, and of course in national, international, various recognitions. HSA is the only university in Pakistan to have an UN Academy Impact Factor. So we are UN Academy Impact University. We are ISO 9000, ISO 17000, ISO 22000 certified, and of course we are in the process of starting our own accreditation system of various health organizations in Pakistan, in partnership with some of the regulatory body, ISQA and others. They are approaching us so that we can start accreditation and certification of quality in Pakistan in various health domains. Major development partners, all UN partners are all UN agencies are our partners, and we are working with most of these organizations. The number of MOUs has crossed now 80. And we have a very strong linkage with the industry through the Chamber of Commerce. So what we are doing is we are trying to inculcate the concept of corporate social responsibility, which was only done by philanthropy and charity and NGOs in the past. No government organization actually tapered into this. So I am working with a lot of pharmaceuticals and other organizations without any conflict of interest to start some of the research, and of course some support for our research projects, and of course some support for research and other areas in Pakistan. So this is something. So we have established a new department of environmental health, climate change and sustainable development, and which will be working for these issues of public health like smog and pollution and other things. And we have got 3 PhDs in environmental health in that department, and that is about to launch and kickstart within few days. So that will be a new field. Main focus is, of course, strengthening linkages. So we are also strengthening the provincial health services academies. I must say I'm not been able to do much in this regard. I tried a lot, but there is an issue of HR in the periphery, issue of financing in the periphery, sustaining qualified HR. Whenever you find a very good resource in the province, they are always trying to move to Islamabad. That is a problem, and you can't stop them because they always have a sort of a dream of doing a better quality life for themselves as well. So the issue is that in the periphery, specifically in Quetta Institute of Public Health or in Peshawar Health Services Academy, people are not staying there for more time. But we will try some innovative model in that as well, that how to improve the provincial health services academies and Institute of Public Health and their health reform units. Hopefully we will be able to do something. We have multiple MOUs for faculty exchange, student exchange. Last 2 weeks ago, I was in China. We signed MOUs with 4 of the very good universities of China for urban health and, of course, traditional Chinese medicine and other research in technology, and of course research in digital health, which they used in COVID. There is a linkage going on through ComStack. So ComStack is the body of Commission for Science and Technology of the Organization of Islamic Countries. So Professor Iqbal Chaudhry is a legendary man, and he approached me, and HSA has been designated as the Center of Excellence in Public Health for OIC. So what we are doing is we are trying to, we call it as South-South collaboration. So we are supporting some of the poor countries like African countries, 28 African countries in development of their public health infrastructure and trainings. And in return, we will be getting some support from the high-end developed countries like Turkey, Malaysia, and of course, UAE, Gulf, and Qatar. So the OIC is moderating that, and hopefully, so currently also we are having students from Yemen in HSA studying with us. We offer them scholarships and stay through OIC Comstack. People from Iran, some of them are there studying in Pakistan. Pakistani students coming back and working with HSA. And there are some students from Afghanistan who are teaching in HSA. So this is the last slide, G. Peter Senge, if someone knows, if not, I will strongly recommend to all of you to go and see what Peter Senge, S-E-N-G-E, Peter Senge said in 1992 when he talked about the fifth discipline. So we have utilized the Peter Senge model of fifth discipline in HSA. So instead of becoming a shift from organizational learning from mistakes, we have started a concept of learning organization, doing mistakes and then learning from those mistakes, not waking up after making a mistake. So mistakes are part of your journey. So each of the team member, I asked them to achieve a level of personal mastery in his or her subject. We support them. Of course, after personal mastery, they have to come up with a shared vision so that they don't think northwest, southeast. They should think, they should have a shared vision. And we are all dreamers. So I do not have a place for someone who is rigid, orthodox, or conservative and a negative person. We do not keep people without dreams. So for me, this is one of the biggest achievement that I have started a habit of daydreaming and innovating and make it as a norm. So they come to me, my office on a daily basis, and they do some mental modeling exercises, and some of them, they give a very good idea. So that is something. Of course, team approach is there for the progress. So personal mastery, shared vision, mental model, team approach, and finally, without system thinking, you cannot do. So if I understand the system of Pakistan, I can do something. The people coming from abroad, from Canada, from America, not knowing the system of Pakistan, no matter how brilliant, how intelligent, how good they are technically, they cannot perform here if they do not understand the system over here. So the most significant our strength of HSA is system thinking. We know how the government works, how the development sector works, how the private sector works, how the corporates works. So that is what makes us unique and more apt and more able to deliver something in Pakistan. It's very difficult to work in Pakistan without understanding the system in which we are working. So that is how impossible becomes possible. So I hope all of you must have learned something about HSA and some of the problems of Pakistan. I stop here. Inshallah, together, I am very positive. I'm a positive man, and hopefully we will succeed. Inshallah. Ameen. Thank you very much. And over to you, Professor Amit Saab and Uzair. Uzair, over to you.
Yeah, thank you. Thank you, Dr. Shahzad. First of all, very, very nice and true comment. I think your talk is the best talk of the year. We have been inviting a lot of people. It's very crisp. I salute your time management. Amazing. You are not just a thinker or a degree holder. You are a practitioner of management sciences. So it speaks volume. And very, very impressive. You know, some of them may be understanding all the languages. So मैं कहना चाहूँगा दरिया को कूजे में बंद कर दिया. Amazing. You know how to build it, starting from visuals, showing the divergent activities and the healthcare issues and the solution. Really, I do not have words really to appreciate the talk by Dr. Shahzad. Very genuine, very true. So we open the forum. So may I request first Dr. Akhtar Hamid really to share some of the comments, and then Professor Dr. Sarwat Hussain, and then we will have the question from the participant. So over to you, Dr. Akhtar Hamid.
Thank you. Thank you, Dr. Shahzad. That was an excellent talk. And Dr. Uzair has rightly said that you have put everything into one box, right from showing the real picture as well as giving some solution to that. I was wondering about how did we miss the first, second, and third positions, which you have just mentioned about that we are the third largest in maternal death, fourth largest in children death in the world, and the fifth largest in the TB cases. So who are the first, second, and third?
We are
That's
trying hard to bypass them. We came very far away. Yeah.
And second, you are a champion of public health in Pakistan. So what we know from outside the country that the entire health system is kind of more dependent on our fundraising and donors and different big hospitals, Indus, child health. What percentage of the health system is really supported by the government of Pakistan, if they were not there to help? So that is my two simple questions. Yeah.
Yeah, thank you. I think first of all, this impression that Pakistan health system is run by the donors is absolutely wrong. We are one of the least supported country in health. We get funding and other things in the name of energy and others, and I don't know where the loans go, but in health, the national health account of Pakistan show that less than 1%. So there is a budget of 1,300 billion every year. So 1278 to be exact. In Pakistan, 1,278 billion rupees are spent. Majority of it is spent by the people of Pakistan from out of pocket. I told you it's around 90%. So the role of donor is less than 1%. So if 100 rupees are spent in Pakistan, not even 1 rupee is spent by the donor. So that everyone must understand that this hue and cry of most of the donors, I don't think that it's correct. The national health account show that 1%, and then recent figure, the latest figure which we have is 2022, it's 0.5%. So that is very low. The federal government supports around 14% of the total budget and 22 or 23% by the provincial government. So around 36, 37% spending in the country, expenditure in the country is by the governments. Then 6% is from the philanthropy. So even philanthropy, charity in Pakistan exceeds the donor contribution of all the combined donors. So 6% of the Pakistani health expenditure is from the philanthropy. 6% is from 5.8% to 6% is from the local government, municipal committees, and other public health engineering, we call it. So majority of the, you can easily say, majority of the sponsor of the health system of Pakistan is a citizen of Pakistan. Very simply, if you have money, you will have one of the best treatment in the world. If you don't have money, you just wait or neglect to care. I told you 10% of Pakistan is there. Sarvada, now I recognize you. I met you in Gujranwala. I hope
Thank you.
Thank you. What was your second question, Akhtar?
No, that was it. I gave you the numbers. You told the number about third, fourth, and fifth largest.
So it's like China, Afghanistan, in Nigeria, they are behind us. China is just by the number, because it's the number of deaths we call about. It's not the percentages. So the number of deaths, of course, will be very high in China and India. And because they are 1.6 billion, both of them, fighting for the number one position in population. But India will definitely cross China because of this stable growth in China. So India is now number one and China is number two in the world population. Pakistan is at number five or number 6. So we are soon to become number 5 in population. So it's because of the number. If you talk about incidence and other things, that's why Pakistan became number 1 in diabetes. That's it's not the number of diabetics. It's only 33 million. Maybe this in China and India, more people will have diabetes. But when it comes to percentages, definitely Pakistan has one of the highest newborn deaths, and Pakistan is number 1 in this heart disease, and of course number 1 in diabetes. Ji, Sarwat Saab.
Ji, Assalamu alaikum, Ji. Thank you very much. I just don't want to repeat all the accolades of Uzair Saab and Akhtar Hamid Saab, and I just say ditto to save the time. But I have been working with trying to detach ourselves from Western medicine. And because what happens is that when we emulate Western medicine, all our money is spent on 2 or 3 or 4 or 10 excellent centers of excellence by government, and nothing is left for the population. So what
Yes.
I'm actually doing at this time is, in fact, writing a textbook of radiology to cover those things in terms of diseases and in terms of resources that will fulfill or try to fulfill the needs of LMIC. And I think one of those things the government should realize, that buying 50 MRI scans that they did about few years ago and 200 CT scans will cost about millions and millions of people their primary health care and their their life. So I think what we need to do is to think within the box of our own realities, rather than try to diagnose those diseases that are not treatable by doing very, very expensive tests and a very, very expensive equipment. So that's my one comment, is to localize the knowledge into for the country. Number two,
sorry. Go on.
sorry, quickly. Number two is the dichotomy between the government and the private. Perhaps the government can concentrate more on primary and secondary, and let the private do the tertiary, because they have the money and the reward for it. And then the last point I was going to say is that the research should also be held in technology, cheaper, less expensive technology for our country, rather than importing very expensive equipment. And the people who train, who are here from Harvard and Karolinska, etc., their knowledge of concept should be utilized rather than implementation and system, because they will implement things that is going to cost so much that the budget will be busted. So these are my comments, sir.
Thank you, Sarwat Saab, and I concur. Exactly what you recommended is the policy statement, which I will definitely echo it like this. So remember, Sarwat, when you were in King Edward, Professor Mahmood Malik was my teacher, and if he asked a student of the final year examination by Viva, and if he asked, how will you diagnose a case of pneumonia on roadside? And if someone mentioned X-ray, he used to fail him. He will say, get lost, because I asked, how will you diagnose a case of pneumonia on a roadside in a village? There is no X-ray in the village area. So even if I mentioned X-ray in that period of 1985 to 1991 in a medical college, they will fail us, because they trained us to actually do the clinical decision making, and then only. Nowadays there is no clinical decision making in the country. So if you buy a CT scan or an MRI, 90% of the reports which are coming every day or every week out of those is having the same findings, and you don't change any treatment. It's just like a fashion. So every specialist in the country is not using his clinical acumen. And that was a British school of thought. You remember, that is a British school of thought, British system of clinical medicine. The American system was totally different. It was corporatized. It was like technology intensive, so techno intensive. Now we have adopted an American model of high cost, very high cost technology use, and that is of useless. That is why, America ranked in OECD country at 38 number in health systems because of this issue. So in Pakistan, you are very right, and I think we have to put our foot down. You heard the story of Sindh, robotic machinery purchase and voices on that. So people are now talking about this thing. Hopefully, we have to come up with a local solution. You're right, and we should be training our physicians and doctors in such a way that minimum invasive, minimum intervention is required. And your second point is right. If 16 billion, 14 billion, 12 billion are going to one hospital of center or a provincial headquarter, what is spent for the BHU and RSC is limited, very less.
Okay, I will take some questions from the Q&A.
Yeah,
so there was a comment by Mr. Mustafa that when digital health will be taught in our university.
Yeah.
And the second part of that one is that you addressed about the health inequities. when and how we are gonna, improve it to minimize that?
So digital health is the next upcoming. We have hired a professor, PhD in digital health, and of course, he's a dental doctor and a PhD in digital health from abroad, and he has joined HSA a few days ago. And in a few days, you will find a lot of digital health courses, trainings, and of course, some models for private sector and public sector. We're working on that line. And inequities, that is something which is very bookish. So when I say equity, the problem is equity is according to need. This is how we define equity, providing services according to need. In Pakistan, this actually is overrated, overused in almost all the books and never practiced. Why? Because of two reasons. Number one, equity has a different dimension and different definition by different school of thoughts. But if we talk about health and specifically need in health, the problem comes when you define equity as a statement where you say according to the need. The problem to me is who will determine the need. That is the biggest problem we are having. So if we are saying equitable provision of services, so who is there to determine who is needy of how much? If I keep it to the user, like the user of health services, if I say that he will tell his or her need, तो वो तो पाकिस्तान की एक कहानी है कि पाकिस्तान में कुछ चीज मुफ्त मिल रही हो तो वो कहते हैं मैं तो 2 लैसा, then everybody is more needy. और जो देने वाले को अगर मैं कहूँ कि देने वाला चूज करेगा, नीड डिटरमिन करेगा, तो फिर पॉलिटिकल क्लाइंटेल आ जाएगी, फिर क्लाइंटेल का सिस्टम शुरू हो जाएगा. So it's very difficult. It's more bookish, more textbook than actually practically implicable. So we have to actually, मैं ये कहता हूँ targeting की बजाय ना ये system upscale करें. So system strengthening करेंगे, everybody will get benefit. हम नहीं system बनने देते. It's individualized. It is, that's the problem.
So next question is from Muhammad Ali Qureshi. He's asking that, do you have any structure or boarding setup in your facility? So if somebody is coming to do some research work at your facility.
Yes, we have our own boarding houses. They are almost all of the time they are full. So we have contracted some of the facilities nearby. There are many. Islamabad is not that kind of difficult to get hostels because there are many universities here, and each in front of every university there is a chain of hostels, and we support the students to get rooms over there. It's not difficult.
In your wisdom, what do you think about somebody saying that there is a prediction in 2053, 64% of the healthcare will be by virtual or telemedicine? Will this help Pakistan improving their current structure of the health?
Last 23 years, I have been working in telemedicine. Professor Asif Zafar started it in 23 years ago, and it hasn't reached anywhere. Why? Because there's a huge disconnect between the technology producer and technology user. So the computer guys, they don't sit with the medical doctor. They create a product and they come up in a conference and they present it. They have never talked to a physician. So that is a big problem. So HSA is trying to develop some of the linkages between these two. I don't think that 2053 or 2043 or 2033 can be predicted. There is a term which is known as disruptive innovation. So disruptive innovation is the way, only in that way, you can start using telemedicine. Otherwise, Pakistani people are not ready to talk to a machine or to talk to a person who is talking in a machine right now. It will take another maybe 50 years to reach to the literacy level of that. So it's very difficult. But of course, it is very beneficial. I say in psychiatry, telepsychiatry, tele-ICU. So training of physicians, training of doctors, we have already started. You know, in HSA has trained 100,000. Out of those, 20,000 were nurses and doctors, and 80,000 were community health workers. We trained 100,000 people online in COVID for COVID management. And this was one of the greatest, achievement of COVID, funded by Asian Development Bank. And even the ICU doctors were trained through an ICU specialist of Aga Khan or Indus Hospital or this Bahria Hospital, Islamabad. General Aslam was the lead. So we and Asad Latif from Aga Khan was the lead. I supported that. In 2 years, we trained a huge number of. So yes, telemedicine has a very big role to play, but currently the patients are not, and even the GPs are not comfortable with that.
So next question is somebody saying that we should invest more time in our provincial health developmental centers so we can optimize the resources and optimize the services. There's a one question, I don't know if it's relevant to you or not, that do the health providers, or especially the healthcare professionals, being paid according to the international or to our neighboring countries' pay?
The first one is like you mentioned about, what was the first question? It was about
strengthening our
yeah,
yeah,
it was in my presentation as well. It is one of the goal, and it was one of the goal. We got support from the USAID as well, and we did some interventions in Provincial Assistance Academy KP and other, like in Quetta. We provided scholarship to them. I already mentioned you. I think it was in my presentation that there's a very difficult sustainability is difficult because someone who does a PhD and qualifies for a good position, he moves from Quetta to Islamabad, or from Karachi to Islamabad, or like from Peshawar to Islamabad. That we cannot, protect. That we cannot stop them.
So the last, which is, I think we are almost over 2 minutes. The last question is a little cynical, but I think it is important to ask is, do we have a health system in place in Pakistan, or we only just treat the sick ones? Because if you look at the international thing, there are prevention strategies from the government. If you are 30 years, you do this. You are 40 years, you do this. You are 50 years, you have to do screen this. So that was the question. I think we should, this is my last question.
I think this must have come from one of my students, because I used to talk in similar way. When I say Ministry of Health or Department of Health in Pakistan, I cynically say, and unfortunately, there is no Ministry of Health. It is Ministry of Diseases. And there is no health department, is a Department of Diseases in Pakistan, because you only thing you have in the Department of Health is malaria control, malaria, TB, HIV, hepatitis, diarrhea, something like that. There is no health in Ministries of Health, unfortunately. But we are trying. Nowadays, we are trying for wellness, for longevity, of course, protection and prevention. We have started thinking on those lines. And if people are talking like this, someone like you read that message, if people have started talking, it means my or ours contribution has reached to the people, and they are now talking. So if we will talk as a nation, hopefully things will change. It is most of the time it is Department of Diseases. It's not Department of Health. It's Health Ministry.
Waleed, yeah. Thank you. Waleed, could you let Dr. Bhutta to join in, because he has some question and he has raised his, and I think I missed it. Waleed, Professor Bhutta is on the our participant, and he has raised his hand for that. Could you let him speak?
Yeah.
Well, while Professor Bhutta is coming, I'm just going to ask a quick question. Are you planning to write any books from local books for the local focus from which the students can learn, rather than read, the foreign?
This is my
and
last...
I can help you in that.
Sarwar, this is my, dying declaration. This is my death wish. I must write a book before dying. I don't know when will I leave the world, but I definitely miss writing a book, because, unfortunately, it is very unfortunate that there is no public health book in the world.
No, please don't just write some books.
Yeah, I will write a book, definitely. And I have started working on it. 2024 is the year dedicated for writing a book on public health Pakistan, or something like that, on various aspects of whatever I talked, whatever I learned, and what is the way forward. I think that book is due, because I did a lot of training, and I always try to capture my experience and my learning from my colleagues, my peers like Bhutta Saab and other senior colleagues. So I always, like Sania Nishtar, so I practiced what I learned from them, and it was not there in any book, unfortunately. So there is no textbook of public health which you can use in Pakistan. So I need to have, actually it's my duty. So I will be talking to you.
Is there
yeah.
Sorry, quick question. Is
Dr. Bhutta?
I cannot find him actually.
Okay.
आप
Not a
अगर
problem.
उनको सेल पे कॉल करके देखें.
Sorry, last quick question. Do you have a publication department in your university?
We have an information resource department, and definitely we are publishing a lot of books and other things, but I don't think they will be helpful to me. They will only become helpful when I have something to print. So definitely there are some I will request my students to send me my audio notes, audio lectures. They always record my lectures, so I do not repeat the same things again. So most of the time, next time I will train or teach the same subject in a slightly different manner. So that will give you a very diversified experience and opportunity to write. And I need a software, Uzair. I need a software which convert voice to text for that, and then it will
Actually,
very.
Dr. Sarwat, I think you are the quality person. Can you convey our quality thanks to Dr. Shahzad Ali Khan and the participant? You know the art of doing it, please.
Well, no, I don't. But honestly, this was such an enlightening lecture, and not only really a lecture, it was like a philosophy. And it is clear that Dr. Saab, Shahzad Ali Khan Saab, has not only understands the issues, but he kind of lives and feels it, because some of the issues that we brought up, he immediately kind of understood, got on, and obviously has already thought about it. So there was nothing. It looks as there was nothing that has missed his consciousness and his awareness. And we would like to have him back again, and hopefully next time we can talk about establishing a publishing department in his university. We think that publishing department with its own copy editors and its own editors, etc., are going to help tremendously in not only collecting the literature for the book, but also the journal, etc., is very, very important. So I think Shahzad Ali Khan Sahab. Sorry, go ahead. Sorry, please.
I have Bhutta Saab with me, and if you allow, I think if he wants to say, Bhutta Saab, can you say?
No, absolutely. Yeah.
Please, Bhutta Saab, your turn now.
Yeah, I know. I didn't want to interrupt, but unfortunately, the link that was sent to me did not have the possibility of participating. So I enjoyed your talk very much, Shahzad. I'll talk to you in detail in a week or so when we meet in person.
Okay.
But two comments and suggestions, and maybe one slight pushback. So the comment is, I think I'm intrigued by the fact that you made a statement on people who are doing health economics in Pakistan, kind of doing it in isolation. And I think you're right, that there are very few people outside of you who have done both, as you saw, the benefit risk assessment and evaluation. And I think that's one of the reasons why the policy makers don't usually look at cost effective as a means for investment. Recommendation would be, whatever the number of people, 5 or 6 or whoever, you should get together and form a group that can look at this. The second is, I think, absolutely correct, and others have said this also, there needs to be a convening on the whole issue of public health in Pakistan. Unfortunately, outside of HSA, even the departments of community health sciences and the few public health institutions that exist in the provinces, they don't work together. You already alluded to the issue of the human resource gap, but maybe you can lead this process of whosoever is there, 10, 12, and the provincial folks assembling to create a platform where we can have a serious discussion on public health policies. As you know, we had a recent conference on health research in Pakistan, and we could not give more than a small fraction of space to public health. It deserves a lot more. The last thing I would say is that the one area where I, maybe have a slightly different opinion than yours is on this whole issue of inequity. Inequity is a theoretical dimension. Inequities are unfair inequalities. And jab tak Pakistan mein ye recognition nahi hogi ke we do not have a fair system, a health system that provides services to all those in need, we will not have to do it. When you
Yeah.
come and if we get a chance to discuss, I'll show you empiric epidemiological data. We don't live in two Pakistan. There is not an urban and rural Pakistan. We have 5 demographics.
Yeah.
There are 5 Pakistan. There are
Of course.
Pakistans where quality of life is very good, and others where we are even worse than Africa and our neighbors.
Yeah. You're
So
right.
I think rather than discard that principle,
Yeah.
it is to understand that principle in health programming and to see how we can in our policies get away from this absolutely stupid debate that is currently happening in Sindh कि हम 4.5 billion rupees के मशीनें खरीदें या लोगों को प्राइमरी केयर दें. But excellent talk. I really enjoyed it. Thank you very much.
Sir. Thank you, sir. And everybody heard you because I put you on speaker without asking you. So, Sarwat, आपने सुना? Uzair?
जी मैंने सुना, भुट्टा साहब को मैंने सुना. मैं actually just to tell you that when Bhutta Saab started his academic career, I was there in Aga Khan when Bhutta Saab, he's so much younger when he was
He's still younger.
what was it? Yeah, I was chairman of radiology when Bhutta Saab was
gracefully under you.
Thank you, sir. Thank you.
Yeah,
Bhutta Saab, see you in
Bhutta Saab was instructor in pediatrics when I was chairman of radiology at Aga Khan. So I know Bhutta Saab since, from that time. It just shows that I'm too old for, for this time.
Sorry, I interrupted you, Sarwat, and I think you
No,
were closing.
not at all. No, not at all. I respect Bhutta Saab a lot. बहुत शुक्रिया. Thank you very much indeed.
Akhtar was right. Akhtar was right because उनका मैसेज मैंने भी देखा, but somehow उनका लिंक ड्रॉप हो गया. तो फिर मैंने
नहीं, आपने बिल्कुल ठीक किया इसलिए कि he is a pride of Pakistan. और बस ये हुआ कि भुट्टा साहब की वजह से आपकी मैं पूरी तारीफें नहीं कर सका. तो
तारीफ का भी कोई काम भी नहीं किया आपने.
Thank you very much. बहुत शुक्रिया. Thank you. Over to Uzair bhai.
Thank you very much to all the participants, particularly for your patience and staying connected till the end of the webinar. We are really thankful to you because nothing is possible without the participant and the technical team led by Waleed. Thank you very much for organizing all the activities, and say goodbye to see you next time after a couple of weeks. Thank you very much, Dr. Akhtar. Thank you very much, Dr. Shahzad, and goodbye to everybody. Enjoy your weekend and all the best wishes from here.
Thank you very much. Thank you, Ji.